Hi, everyone. I'm Scott Podolsky. I want to welcome everyone back to our final Department of Global Health and Social Medicine seminar for the 2021 academic year. We're proud to end the year with an MMSc Alumni in Action Talk. And I'm proud to introduce the director of the Master of Medical Sciences in Global Health Delivery Program, Joya Mukherjee. Dr. Mukherjee is Associate Professor of Global Health and Social Medicine at Harvard Medical School and Associate Professor of Medicine in the Division of Global Health Equity in the Department of Medicine at Brigham and Women's Hospital. She teaches infectious diseases, global health delivery, and human rights to health professionals and students from around the world. And she'll have the opportunity of introducing our esteemed speaker for today.
Great. Thank you, Scott. Great to be here with everybody today on a beautiful day here in Boston. And I'm just really excited for all of you to hear from Dr. Ana Cristina Sedas, who is a friend. She's a light for everybody, and she is a graduate of the MMSc Global Health Delivery Program this year, 2021, a very difficult year for our class, being interrupted halfway by the pandemic. And really limiting the travel that people normally do and the field work they could do. But despite that, Ana Chris's passion for migrant people, or people on the move, as she likes to call them, just shone throughout her entire study. And she ended up producing just really a wonderful thesis looking at tuberculosis as a sort of marker for vulnerability in migrant populations, and as a way that was helpful to interrogate the health system and to really look at how it addresses vulnerability, long-term care, and really the social and political determinants of health. So Ana Cris will be talking about her work with people on the move. She has a paper that we will share with all of you that she wrote with Salman Khashoggi, Michael Nipper, and others on tuberculosis in migrants, looking at Peru, and South Africa. She did a case study of a Guatemalan man who migrated to Chiapas, and so we'll share those papers with you as well. But we're just so delighted to have the indefatigable Dr. Ana Cris Sedas with us today. So Ana Cris, all yours.
Thank you, Joya. And I just have to say that, one, it is such a pleasure having someone that I truly admire as a human being and as an advocate. Introducing me, I feel the lowest of the advocacy chain, but I am very honored and thrilled. And I just have to say, I was looking so much forward to this talk. I am looking absolutely forward to this talk. However, life circumstances happen, and I didn't have the exact opportunity to just build the most amazing presentation, but who had time and opportunity to build the most amazing presentation during COVID-19? And before I start talking, I would first like to just say that I just came from the hospital. My grandmother's at the hospital. And the reason why I share this was because as I was with her, a month ago, she got ill, and we were able to be privileged enough to find oxygen. And at the same time, reading the news in India, people didn't have oxygen. And at the same time, reading the news in Brazil, people didn't have oxygen. So we talk about privilege. And my grandmother is not more than the grandmother of a Guatemalan migrant, or so I just blanked out. But I just wanted to say that when I talk about people on the move, I talk about real people. Talking about my grandmother, I'm talking about your sister, your brother, your father, your cousin. We're talking about people. And this is very important to say, because we all have the right to the highest attainable standard of health and well-being. However, unfortunately, the circumstances, the policy, the politics hinder that possibility of achieving that inherent human right. So this talk will be in dedication of all of those that are on the move or will be on the move, and those who have finalized their migration journey. And with that, I will start my presentation. Okay, it looks like I can't share screen. Looks like I can't. So I don't know if someone could. Oh, there I go. So with that said, please interrupt me. Please share any thoughts, just let's go ahead and have this nice conversation. I'm going to try to be brief, but I am never brief. So I will do my best in sharing this with everyone. So this talk is about my biosocial analysis of migration health in Mexico, Latin America, and beyond. And it explains when theory meets delivery. So this talk, different than my thesis dissertation, I will focus a little bit more on the biosocial part, because one, it is critical for us global health scholars and health professionals to think about these living conditions when we encounter someone on the move, an irregular migrant, a circular migrant, a labor migrant. We need to consider this when we meet them. It could either be in a healthcare setting, it could be on the street, it could be reading a news article. We need to think about that when we address migration and health. So a couple of months ago, before the beginning of this master's program, which I am eternally grateful for, I set out on a quest to find answers into why many of my patients and people I met along the way avoided or even feared searching for or accessing health services. Why so many of them would get sick or even die in countries where they recognize as state parties to international treaties that protect them from just that, while in some other cases, countries that refuse to acknowledge health as a human right. It was that I found myself discovering that there are ways in which we, in collaboration, are able to close the gap between the many barriers experienced by my patients by using not only science, but understanding their theories and sharing how to bring together the theory into practice. This picture was when I was finally able, my first day of class in person. And that brought me to realize, but what exactly is migration and health? I have been working on it, but how did I actually live it and understand it? And why does it all matter? So over the past few years, research has shown that migration can be associated with improvements in health statuses while also conferring increased risk and exposure. This was actually the first time that I came across this article, and I found it all amusing and highlighted absolutely everything. But questions still remained, and this is what the master's in medical science taught me, and how to find the answers of the conditions in origin country and their transit. So whether the process of migration itself improves or diminishes an individual's health depends on the conditions of their origin of country, cumulative exposure to internal confounders and external confounders, and the health risk encountered throughout their transit. But it also has a lot to do with their environmental and transiting conditions in their host country, as well as in their transit country or resettling country. And these conditions are mostly structural, they're political, they're economic, and they're social. They're structured by agreements between groups of individuals in power. And these groups of individuals in power have in a way reshaped the value and the opportunities that people have to thrive in life or to fall ill in life. So to look a little bit forward on what is migration and health, we need to look at what is the theory. So initial theories on migrant health brought forward by Macbeth, Shetty, and Cruikshank in 1984 and 1989 attempted to understand the differences in migration and health. Oh, sorry for the image here. The differences have been commonly attributed to race, ethnicity, culture, or biomedical factors. However, legal immigration status, as well as structural, political, and economic forces disproportionately affect migrants' health before, during, and after their migration journey. So these have immodest claims of causality is to attribute the differences in health outcomes observed in migrant populations to an individual biomedical or cultural characteristic, which is something that we fight against in our department, is to displace the government's responsibility to addressing the political, economic, historic factors of addressing the real migration and health. This approach ignores the fact that social, ethnic, and racial categorization of people reinforced by the passport system and the quota entry system cause more social and health inequalities. And we need to think of migration as a social determinant of health. And besides, the conferring risk of migration can also be determined by improving the health status. So when we look at the health status of people, migrating might permit either improvements of the very structural conditions that keep someone sick or in danger, such as poverty, war, natural disasters, or the preconditioned migration as a result of climate change and the need for survival. But it's important to revisit here the healthy migrant effect, which I think is the only one you can see from my beautiful picture here, and the salmon effect. So in terms of the healthy migrant effect, is a theory that has been pushed forward in migration and health scholars. And it's the observation that in some places, migrant populations are healthier than their host populations, which is usually attributed to the young age and the health profile of individuals who decide to migrate, as well as the healthy migrants who are more likely to choose to take over this migration journey. However, the salmon effect suggests that migrants who fall ill while in transit or after years of resettlement prefer to make their journey back. However, there's an important overestimation or underestimation that will likely shift the healthy migrant effect hypothesis away or towards the null. And it depends on a lot of factors, such as the quality of data collected, the accessibility to actually interview migrant individuals. And this goes out to Mary Kay, as she taught me this. While such assumptions of migrant health might have historic migration sceneries, contemporary shifts in migration, mobility, and demographic might depict a very different scenario. So this image, the reason why I brought it up is that since 2018, there has been more and more feminization of migration accompanied by children, spouses, elderly, with underlying chronic and living conditions such as diabetes, heart disease, cancer, asthma, mental illness, HIV, and tuberculosis, all of which might worsen and get complicated throughout their migration journey. And because there's a very strong influence on the social determinants of health of both the migration journey and the health of migrant people, to truly capture the scope of such relationship is to look at the biosocial lens, to consider that these are a series of mutually reinforcing events that trigger a cascade of health outcomes. And in short, for the world, researchers, lawyers, health professionals, and ultimately policymakers to fully address the health of migrants, there must be a merging of the biomedical understanding of illness and health with the biosocial knowledge of the root causes of illness and health in migration. It is also very important to recognize the root causes for migrant suffering and ill health. A one-size-fits-all strategy will not succeed if we fail to consider, the multidimensional and dynamic experience of accessing healthcare for people on the move. And amid a global pandemic, healthcare and prevention of avoidable harm, regardless of the nationality, eligibility criteria, remains a luxury that only a few people have access to. So this is when I stop and question if the human right to health is in practice only guaranteed for such or only for passport or document holders. So to start this experience, we get to see that in the framing of there has been 200,000 people on the move and still healthcare remains a challenge for them. And despite global commitments of leaving no one behind, governments and institutions continue to neglect that explicit inclusion of all migrants in healthcare systems and policies. We first need to frame what is migration and health, and why is migration a social determinant of health? It can improve our status or diminish, as I already mentioned. There are theories that talk about the positive or negative health outcomes resulting from migration, and it could be a result of cumulative exposure of structural, political, and social, as I mentioned, but also could alleviate those conditions that led to migration. Migration policies and health policies both have failed to explicitly include and consider the health needs of migrants. It can improve the status of people on the move if you move from levels of high violence to levels of low violence, but it could also improve illness and death if you move from one place to another without policies that are designed to consider the health of migrants and without health policies to consider that there are migrants on the move. So when we talk about this presentation, I will explore in detail the syndemic and the structural vulnerabilities of people on the move. So first, I will emphasize the structural, political, and social factors that both emerge currently and historically, and they have a significant impact on the lives and livelihoods of individuals and his or her health status, and ultimately influencing the right to health. I will then briefly outline the legal frameworks of migrants in access to healthcare in Mexico, which will include international treaties, interpreted international law. And then I will illustrate through a case study the individual experience of a Central American migrant that was cared for the team from Partners in Health Mexico. I hope Marta's here. And I wanted to also thank Marta for this lovely case. I will discuss how individuals experience and how it reflects on the global challenge to uphold the right to health, specifically by illustrating access to TB care. But when we talk about tuberculosis, it is a disease that is socially caused, and it has a cure. It affects vulnerable populations at higher proportions, overcrowding, malnutrition, lack of access to healthcare, all of which have been proven to be more present amongst migrants when considering their transit, working, and living conditions. And it also illustrates the many challenges for migrants to access healthcare, as TB is preventable, diagnosable, and treatable disease, and one that is built within the healthcare systems. As the case for Mexico, TB is free for all citizens and non-citizens alike. And therefore, by illustrating how TB services lack proper functioning for migrants, individuals, that what can we expect from other services that are even more limited and attract less funding? And at the end, I will go just briefly into this concept of how to look at healthcare delivery. So one thing is to criticize the approach, criticize how things are moving, and another thing is to actually go deep into it. So just to briefly explain a little bit, why did I start all of this? And why is it a nice question to ponder on? So people often ask me, why is it that you advocate for access to healthcare for migrants and not even locals have access to care? And as I start working on this question, I face the actual scenario of I was working as a volunteer physician during the pandemic in this master's program, and I had these questions pondering over my mind. And it comes to the same question as my grandmother. Why did my grandmother have access to healthcare, and why did someone else's grandmother did not? What is the difference in how we deliver care, who receives care, and why we are dividing into nationality, document holder, if you have access or not to health insurance? Why do we have to question this if it is signed and ratified by many countries in the world? But the question is, the difference, and why I focus on migrant health is because if we ensure that the most disadvantaged groups have access, migrants and people on the move included, we're ensuring that everyone else has access to health and the right to health. And systems only work when all roads lead to the same goal, which is the highest attainable standard of health and well-being. And as for migrants, the road is not only rocky, but unstable, unsafe, and oftentimes does not exist. So we're going to go a little bit on the structure of how I will be talking. And I would really like for you to keep this in mind. You can make notes, we can make comparisons towards the end, but this is a little bit of the framework that I have been using with my mentors, colleagues, and friends to try to understand, and this will come together towards the end of the conversation. So when we look at this image, we think about syndemic. We've been listening a lot to the word syndemic. And a syndemic happens when two or more health conditions coexist in a population, with which the interaction of chronic conditions such as poverty, discrimination, chronic stress, structural violence contribute to illness or disease progression and ultimately increase the risk of illness and death. But what if we add mobility to the picture? What if we add poverty to the picture? What if we add structural violence, structural vulnerability, social suffering to the picture? What happens then? In the case of migrant populations, an example is frequent for syndemics. So there's been some studies that explore the syndemic experience of migrant individuals, and this is the presence of two or more health conditions coexisting and interact with social conditions as discussed. And there are studies, for instance, on Devan Puman, that talks about malnutrition and tuberculosis, type 2 diabetes and depression, alcohol abuse, and psychological trauma, among others. In the case for Central American migrants and transcontinental migrants heading northward through Mexico, this syndemic scenario has rarely been considered, even in the light of a COVID-19 pandemic. Despite dramatic shift in migration demographic and burden of disease of those who head northwards, public health efforts continue to focus on minimal standards of provision, such as temperature recordings, ensuring minimal standards of water provision, of soap, hygiene products, but aim at maintaining cost effectiveness of public health programs instead of looking at the cost and the effectiveness of such programs towards the population that is targeting, which are migrant and individuals that are or could be on the move if it's not improved. And the vulnerability of developing one or more multiple diseases is called a syndemic vulnerability. This term was coined by Willen and Knipper, and this overlapping burden of disease in migrant populations that is attributed to the environment that is aggravated by this political adversity. So these conditions, by observing migrant health by this endemic vulnerability, we look at the lens and we're able to explore the synergic and often interactions of comorbidity, sorry for that, health conditions, especially under circumstances of structural and political adversity. So when we look at structural violence, the last one, we look at forces. They're invisible because we can't see them, but they're embedded within institutions, governments, organization, and they're created by unequal power dynamics and unequal opportunities. And then they're structural because they're embedded within society, and they're violent because they harm people. So when we put all of those together, we look at the actual experience that is lived by migrant populations. So this endemic vulnerability that is enhanced by the structural violence, that is enhanced by the structural vulnerability of migrants, can further be exacerbated by public health policies, as mentioned, that focus only on national and local efforts to address the needs of citizens, that are limiting access to healthcare based on immigration status, based on legal documentation, based on race, based on ethnicity, based on access. So this form of geopolitical and nationalistic control over individuals, over their health, and ultimately their impact of life has been described as structural vulnerability. And when these conditions occur, they cause increased risk and illness and death. So what we're looking at, and this was just the framing, we talk about structural violence, endemic vulnerability, structural vulnerability, and syndemic. I lost the other one there, but this is not something new. This is not something that was created due to an emergency of public health concern. This is deeply embedded in history. Structural violence in Latin America is very much alive. It is in our history. It is in our culture. It in which colonial powers offered religion rather than healthcare, enslavement opposed to land ownership and exploitation instead of indigenous prosperity. It is in our borders, once free to move through and throughout, and now is restricted by immigration policies under Title 42 expulsion, national security, same between US and Mexico, and now happening between Mexico and Guatemala. It is in the change of power from European colonizers to American neoclassicism, driving Latin American market economy and sponsoring violence. It is not historic. It is not only historic, it is so deeply penetrated in our systems. They're invisible forces that we cannot see. And even though the systems are created to improve the health and livelihoods of people, they're still created under this assumption that individuals are right holders, and that only those who the state recognizes as right holders are able to have the right to access healthcare. It is within our systems that finance. It is within our systems that create surveillance. It is within our economic system. And unfortunately for Mexico, it is within our only healthcare structure. So migrant discourse has been, and financing and activism has deeply tried to penetrate that migrant health historian perspective of invasion. Migrants were seen as invading rather than focusing efforts on addressing the conditions which drive these individuals to other countries, the conditions which create illness for these individuals that ultimately end in your country. So this is a post from a telegram from 1918 that depicts how migrant individuals have been for more than 100 years dehumanized into labor machines, risking national progress and problems to be dealt with. Migrants have been seen as a problem, and the structure, institutions, and organization caring for migrant health locally and nationally have been those that are mostly focused on protecting national sovereignty instead of protecting the right to health. But this was 1918. So human rights came in 1948 because 1948, they decided that human rights were worthy of being written down. But this is not something new. Human rights, a person is born with those rights. You didn't need a document to be signed, but okay, let's take this document. However, one of the most important legacies, as mentioned from the past, is one, aspirational. It is not legally binding, but it acknowledges for the first time that all human beings are equal in dignity and rights, including right to shelter, movement, seek asylum, and healthcare. However, their explicit inclusion of irregular migrants has been quite overseen. It was until 1966 that the need to explicitly include the right to the highest attainable standard of health and well-being was created, and it was due into effect until a couple of years later. But here, it was the first time that they mentioned the right to health for all people, the US being one of the countries that did not consider the right to health. And this I learned under a very interesting fact when I was giving a talk at the Consulate of Mexico in Boston, saying the human right to health, and a student from the MMSc program swiftly corrected me, and she said, in the US, it's not a right to health. If you have money, you get help. If you don't get help. So it comes to that, those legally binding documents that drive this advocacy towards inclusion of all migrants, regardless of where they're from. So in 1966, there was a need to explicitly include the right to the highest attainable standard of health and well-being. However, migrants were not explicitly included until the general comment number 14, where the right to health for migrants was explicitly mentioned. And in fact, something that I would like to advocate and argue against is that migrants were mentioned as illegal immigrants. And this is a legally binding document. And this language needs to be changed if we want to move forward. So moving forward, in a couple of years later, the Millennium Development Goals focused on investing on health for migrants, as it was necessary for development, rather than seeing the right of individuals separately and the right to access care. You could see, I could send a document over that clearly expresses as a campaign saying, hey, countries, if you want a healthy economy, you should provide health for migrant individuals, rather than, hey, people have rights, and then we look at SDG, the population wasn't improving. It was mostly addressing the social conditions that drive migration. But what happens to the people that are already on the move? What happens to those that are resettling in a country? Who protects them? How are they protected? And then we have finally the Global Compact for Migration in 2018, where they recognized for the first time in history, after 1948, that migrants have to be recognized. All migrants, not only refugees. There's a refugee compact in 1951, but all migrants have the equal right to access health and livelihoods and protection. After 73 years later of history in the making, what has changed from this, where migrants are seen as disease carriers, to this? This was only in 2020. So all types of international, documented, undocumented migrants, seasonal, circular, labor, return, international, all of them are vulnerable to experiencing prolonged periods of lack of resolutive care. For those living or traveling undocumented, the accumulation of negative experiences before, during, and after their migration journey are more likely to reach a tipping point towards negative health outcomes. However, in governments, the social protection schemes failed to explicitly mention migrants. And this is particularly true for migrants transiting or resettling in countries that fail to commit to the legally binding document. And this is the case in Mexico for Central American and transcontinental migrants. So the aftermath of colonization, foreign intervention, industrialization, natural disasters, economic crisis, state failures, all of that has led to impoverishment and violence. And this has forced thousands of Central Americans and extracontinental impoverished, desperate, irregular asylum seekers, refugees to move northwards to ensure their right to health and dignity. So you could see in this image, the peak of 2019, increasing levels of poverty, extreme violence, state failure, and climate change drove around 860,000 apprehensions at the US-Mexico border. And this is in contrast to what Mexican nationals, the National Immigration Authorities in Mexico reported is about 172,000 individuals in Mexico, while you could see the numbers. So the situation experienced by Central American migrants traveling through Mexico is an excellent representation of the broader socioeconomic, cultural, political, and unjust disparities occurring globally against and towards migrants. And for the purpose of this presentation and the work that I have been conducting, Mexico was chosen for an in-depth examination and analysis as it typifies and exemplifies similar, not identical, historical, political, and economic social forces in Latin America that impact the lives. Why do I emphasize on this? Because the global discourse of migrants, they talk about Central American migrants, they talk about European migrants, they talk about African migrants, but each country has a series of historic, political, social, and economic history, as well as forces that drive migration. We need to look at that, and we need to tailor-make our approaches. So this large-scale migration was manifested since 2018 and never before seen migrant caravans comprised mostly of unaccompanied minors, elderly migrants, family units, members of the LGBTQ community, and people with disabilities and chronic conditions. A total of 9 caravans, between 3,000 and 6,000 migrants each, have transited through Mexico since 2018. And this talks about the mounting pressure brought by hidden and quite evident social forces that continuously push people into conditions that impact their health and livelihoods, even in countries where conditions are similar to the ones they fled from. The sharp increase on the image you could see on the left in asylum claims between 2014 and 2019 illustrates specifically that point, the social, economic, and health inequalities in Central America that are far from being resolved. In 2020 alone, a total of 32,000 individuals from Guatemala, 38,000 from Honduras, and 8,000 from El Salvador presented themselves to Mexican authorities. However, 53,891 migrants were returned to their country of origin, despite international recommendation by human rights bodies to avoid deportation practices. Yet thousands remain stranded at the US-Mexico border under the MPP program following the surge of migrants under Title 42. There's some efforts currently at the moment. Yesterday, there was an announcement by the Biden administration that they will revisit all of those closed cases. I will have to see what happens from that. But I'm happy to see that there's some sort of reparation from all of the damages, at least legally, for the individuals. But we could see here that, surprisingly, this is the first Central American caravan, and you could see here the sharp increase in migration from Central American individuals from Honduras, Guatemala, and El Salvador. Mexico was quite stable here. This migration, Mexico transitioned from a country of expulsion of migrants, a country that sends migrants, to a country that receives migrants. But what happens here with the sharp increase of Mexican apprehensions at the US-Mexico border? So with this data, one might only wonder, why is it that a country in which socioeconomic conditions forces thousands of people to migrate to the US, how has it become a major hosting country for the poorest of Central Americans? And this also raises important questions into Mexico's capacity to address the needs of resettling Central American migrants when its own citizens are increasingly attempting to leave the country. So looking back at the relevant international treaties and agreements Mexico has signed and ratified, and because of time, I'm going to be a little bit short on this, particularly those treaties and agreements that address the right to health. An obvious thing comes to mind. Mexico, as we could see in all of these, has the legal obligation to protect, respect, and fulfill access to healthcare for citizens, as well as migrant asylum seekers and refugees. However, and in Mexico, we have this saying, del dicho al hecho hay un gran trecho, which means basically from what you say to what you do, there's a huge gap. Mexico takes pride from the international commitment towards health and human rights. Still, It took Mexico 15 years to ratify the International Covenant for Economic, Social, and Cultural Rights, which talks about access to the highest attainable standard of health and well-being, and 2 more years to implement it as Article 4 in the Mexican Constitution. Article 1, in fact, in the Mexican Constitution states that everyone in the country, every single person that is transiting, residing, or living in the country has the right to enjoy all of the treaties and agreements that Mexico has become a state party. So why are we still questioning, and why am I still investing my entire life in access to healthcare for people on the move in Mexico and Latin America and globally? And 28 years later passed, and Mexico was only bringing forward their explicit commitment to include access to healthcare as we all guaranteed to enjoy the right to recognize in our constitution, including treaties and agreements, as I have mentioned. However, major discrepancies exist between theory and practice, del dicho al hecho, towards the right to the protection of health in Mexico. And for migrants, the right to access health and social services was not represented until 2014, 33 years following Mexico's commitment to respect, protect, and fulfill the right to health in the General Comment 14. So in theory, Mexico agreed to carry out these 3 main duties: respect, protect, and fulfill, ensuring that all migrants, regardless of where they're from, they have access to services, and that all services are available, accessible, acceptable, and of good quality. And this was specified within the General Comment number 14, which was a specific group of individuals overseeing the right to health. Access to healthcare for migrants is both fragmented and underfunded, nor is sensitive to the migration experience. So this is what we will talk towards the end. So when we look at migration and health, just a little bit of what is going on in Mexico. There was a study conducted in 2015 by René Leiva that said that surveyed migrants across the country, and they said 6 out of 10 migrants needed care. And they asked them, what do you do for those 6 out of 10? Where do you go to? So surprisingly, 80% of the individuals said that they would prefer migrant shelters, and only 1.8%. And just to mention, this is in a country that is a state party to the right to health. This is in a country where you have Article 4, that we believe in the protection of the right to health. This is in a country where you have Article 1, where all people transiting, living, have the highest, are able to enjoy the treaties and the agreements. And this is in a country where they also signed and ratified multiple agreements where migrants are included. Only 1.8% go to government-funded primary health care. Why is this happening? So local actors have identified that migrant individuals are not likely to go to attend themselves in government-funded primary care because there's no available, accessible, acceptable, and services of quality. And we will go into detail towards the end. So when we think about what was happening in 2018 and 2019 that reflects Leiva's study, we find from an IRC publication that 32% of the migrant individuals in 2018 had health needs and 41% in 2019. So increasingly, some of the main causes are known: upper respiratory tract infections, fever, diarrhea, but you also had chronic conditions that were not considered in healthcare delivery schemes. You have underreported and undertreated mental health needs. There was a study conducted in 2017 for migrants that transited through Mexico, ended in Texas, and they asked them what was their need. 32% expressed they had PTSD, 24% major depressive disorder, and 17% both. And another study from MSF also found that the exacerbation of that mental illness was their transit exposure of violence in 62% of them, and 23.3% international physical violence. So when we look at, okay, COVID-19, health system preparedness, response, inclusiveness, what is going on? What was the scenery of 2020? It was the same thing. In 2020, there was a survey conducted by Mixed Migration Center between Guatemala and Mexico, and they surveyed migrants in Guatemala and Mexico. And surprisingly, you asked how many people, if they need care, where would they go? And only 84% said that, sorry for that, this is here. So 81% said that they will receive medical assistance in shelters. So why shelters? Why shelters and not government-funded care that it's 2%? Those are some of the questions that I would like to ponder, and we could leave towards the end of the discussion. The IRC made this assessment, and people reported feeling unsafe to leave the shelter. There's a limited freedom of movement. There's a cost to medical care, no insurance, that they didn't know that they could be assistance, and there was no medication available. So the civil society has taken over the government's responsibility to protect, respect, and fulfill the right to health. And there's a clearly avoidable lack of staff, space, systems, and social support. But what is happening? So with that case, I would like to go specifically to the case of Avelino. And it was compiled by a combination of journalistic reportings by Compañeros en Salud and cross-referencing with MMSc alumni, Doctora Marta Arrieta. And I think Doctora Marta Arrieta for this case, one, because it saved my thesis, and two, because it showed me the world, it opened my eyes to TB care and how TB care was only, for Avelino, was only successful because of the efforts of this incredible organization that really takes pride out of being the antidote of despair. But why do we need these organizations where there are systems that are there to protect the individual? So a few months ago, Compañeros en Salud published the case of Don Avelino, a 32-year-old seasonal migrant worker from Huehuetenango, Guatemala. Avelino was born in a rural living Guatemalan family. However, at age 14, Avelino lost both of his parents. In 2002, Avelino at age 14 had little to no access to formal education in rural Guatemala. And this was true for most children around Avelino's age. The lack of opportunities and death of both of his parents forced Avelino to work in formal jobs at the haciendas of landowners. Around the year 2009, Avelino, at age 20, took the risk of migrating to Mexico to find a job as a farm worker, as economic struggles increased due to lack of employment. By that time, he became one of 1.4 million international migrants from Guatemala who left their country to improve their situation. Moving from Guatemala to Mexico and back became part of Avelino's identity. This is called circular migration, and the primary source of income for his family. In fact, he contributed, according to 2016 census, 13.10% of remittance. He contributed to that. So over time, even circular migration became difficult, as this was not only enough to afford traveling back and forth, but he wasn't able to move back to his family, and still his family dependent on his remittance. So in 2016, Avelino decided to stay in Chiapas, where he remained until December 2020. Avelino had been sick for a very long time. While Avelino's diagnosis and treatment for TB is provided at no cost at public health sectors in Chiapas, in practice, Avelino had multiple barriers preventing him from reaching available, accessible, acceptable, and of quality services. So Avelino had normalized his condition. The structural and everyday violence experienced by Avelino and many other people on the move, such as individuals from Central America, have socialized that scarcity and have limited their ability to seek care, to receive care, and one that is of quality. So some of the barriers that Dr. Marta Arrieta discussed and saw with Avelino were the barriers to reach health services because of long distance. Avelino had to travel between 3 to 6 hours walking or in car. The cost of losing that day of work, and the cost of travel. Not a lot of information of where to go to, and the lack of social networks to support Avelino to move from one place to another. And Avelino had also questioned and lost faith in the health system, previous health-seeking experiences, as well as those he heard during the peak of COVID-19 in Mexico. And Avelino said, they say people were killed in the hospital and I didn't want to die. And when you look back at the journalistic reporting of what was happening during that time in June in 2020, a lot of people were dying in rural Chiapas because services were not available, accessible, acceptable, and of quality, not only for migrants, but for everyone in the community. So barriers to access health services, despite the service being free, you have long waiting times, you have lack of surveillance, you have systems that have verticalized COVID-19, and you have a lack of actual resources and available services for all people. So by the time Dr. Arrieta saw Avelino in Jaltenango, Chiapas, he was renting a small room in the capital city where he had gone for a medical appointment. And he was cachectic and dehydrated, and he knew he would die soon. Laying down, preparing for death, he saw a young passerby through his window, and he asked for a glass of water. He fainted shortly after. Luckily, the passerby was a volunteer at Compañeros en Salud, Partners in Health Mexico, who swiftly arranged Avelino's transportation to the hospital. So due to his respiratory symptoms and lack of testing capacity for COVID-19 and TB at the hospital, Avelino, which was highly immunocompromised, was transferred to a COVID-19 ward. Whatever it was, it can't be COVID. Very smart Dr. Marta Arrieta remembered experiencing and thinking because of her knowledge on global health and social medicine, as well as her experience, and please correct me if I'm wrong, Marta, she knew this was TB. So the limited testing capacity and processing capacity and relying only on chest x-rays was the only way Avelino was able to get a diagnosis. However, medication was limited. But fortunately enough for Don Avelino, he had access to TB medication that belonged to one of those patients that had been lost to follow-up and proper sustained accompaniment provided by SES. While diagnosis and treatment in TB is provided by no cost in the public health sector in Mexico and in Chiapas, irrespectively of nationality and immigration status, Avelino had multiple barriers to access healthcare, irrespective of his nationality and immigration status. Avelino, unfortunately or fortunately, was able to reach access to available, accessible, acceptable, and of quality services. And Avelino completed his treatment 6 months and was able to join his family in Guatemala when borders opened. So this is a picture taken by SES. This is how a couple of days or weeks later, when Avelino was able to eat, and this was SES team that was able to help Avelino recover. So when Avelino was moving from one of the most impoverished places to another. However, the amount of care Avelino would be able to receive in Chiapas falls below the average, what Mexico is capable to offer. Yet, despite Guatemala having a slightly weaker health system, as we could see in the indicators, Avelino's experiences attempting to access healthcare almost killed him in Mexico. So immunization coverages were below, as we see in the indicators, were below international recommendation standards, especially pronounced in Mexico with 76%, even below Latin American. And in 2019 alone, both countries experienced a delay in achieving the TB strategies. And also they had an important shortage of BCG vaccines pronounced in 2020. When we look at this questioning of the BCG, why didn't we have BCG immunizations? There was a press conference from Mexico in 2020 where the members of the health ministry blamed this low percentage coverage on global shortages of BCG vaccination. However, the WHO swiftly countered Mexico's claim and insisted that there was no global shortage and recommended to look at national cold chain distribution and immunization stocks. So that displacement of responsibility from a country in recognizing that they don't have what they need, even if this disease, even if it's covered within healthcare delivery in Mexico, that displacement of responsibility and blame severely impacts the livelihood of individuals, and for sure individuals under minor individuals that could potentially be tested positive for TB. So there was another interesting study between 2017 and 2019 amongst 455 traveling asymptomatic migrants. 2 out of 10 had latent TB. The highest prevalence of TB was amongst those who had been residing more time in Mexico, which talks about the syndemic vulnerability of migrant individuals of being exposed to malnutrition and therefore TB, or moving from one less endemic or less prevalent community to another with the social and living conditions, what we discussed earlier. But there were also lower rates of latent TB in Central American migrants compared to Mexican migrants, which talks about these conditions. So the first section introduced migration as a social determinant, and it's often denied by a series of social and structural forces. And Avelino's case highlights how many challenges of economic, logistical, social, political, and cultural tamper with the right to health. However, the health-seeking experience faced by Avelino is one shared across 281 million international migrants around the globe. Avelino was an outlier, but he was not an outlier because he was a migrant. He was an outlier because he was actually able to receive care compared to Central American migrants in Mexico and migrants globally. So the case study, as Joya mentioned, talks about the experiences of migrant individuals during COVID-19, where it talks about the social and political determinants of health. So you have individuals from Mexico and Guatemala, as we showed with the closure of borders, limiting the ability to move from one country to another. The paper also discussed case studies in Peru, where you have dozens and dozens of Venezuelan migrants moving. You have the case of South Africa, where you have labor migrants mining in mining areas and increased risk of tuberculosis. And you also have areas where you have difficulty and challenges to provide humanitarian aid. And all of these countries have, in a way, committed to addressing these conditions and right to access healthcare for people on the move. This is, if you're interested, I'll be happy to show and to share this paper. But the framework that was discussed at the beginning is the one that we use to discuss the TB health policies and services for forcibly displaced individuals. And with this, I would also like to thank the authors who were in the field writing these case studies and sharing with the world the impact of how COVID-19 derailed progress of TB in around the globe, especially illustrating how migrants are at particular risk of illness and death of tuberculosis and other diseases that come together in a syndemic. So just to discuss a little bit, and I'm about to wrap up. The upstream of economic, structural, and political determinants of health affect not only the individual, but all individuals around the globe. There's previous work that utilizes human rights frameworks, such as the AAAQ, that have been assessed, that assess health service delivery. However, they're limited to addressing the supply side rather than the implications of low adherence to human rights and policy implementation. And this does not consider the user's experience. Access to healthcare for migrant populations in Mexico and around the globe, despite referencing human rights instruments and treaties, continue to be designed to solve biomedical problems without thinking about what I mentioned before. And it's not me that created it. It's a body of literature of people in global health and human rights and international law that come together and discuss how migrants are at an increased risk. In a one-size-fits-all approach or recommendation does not fully capture the complex, dynamic, and multidimensional experience that is referred by migrants, and it's seen within the migration and health literature and scholarship. And it is critical to rethink the delivery for all migrants by leveraging from human rights in migration, global health, and social medicine, and people's perspectives. And with all of that said, and having in mind the case of Avelino, I would like to introduce this very, don't think that this is already done, or it's just this very early stage concept, a framework of how to look at health service delivery, considering what was mentioned before. So according to Levesque, in their paper on access, what is access to healthcare, Levesque describes access to healthcare for an individual is to identify healthcare needs. This individual needs to identify healthcare needs, to seek healthcare services, to reach healthcare services, and to actually be offered services appropriate to the needs for care. We have a question here. Oh, perfecto. So coming back to this, so we need to accessing access to healthcare for migrant populations, as mentioned, is a dynamic and multidimensional experience. And it involves multiple dynamic interactions. So on the demand side, we have migrants' chronic, evolving, and acute medical and social needs, shifting demographic, economic, individual agency, lifetime exposure, all of those conditions that were described before. And then we also have the supply side, which includes availability, accessibility, physical accessibility, economic accessibility, non-discrimination, access to information, and all of those who are called the triple AQ. So when we put that together and we imagine the case of Avelino was able, the doors are open to healthcare. The doors are clearly open for some people. Avelino's agency to go in the system is one thing, but Avelino's agency to identify, to know that if he's not in Chiapas and being helped by Partners in Health, would he be able to access TB care? Would he be able to afford TB care? Would he be able to have access to information for TB care and other diseases? And this is why this concept, and I would like to leave on the table, is to see that this person could enter the system and leave the system. This system could be designed with human rights frameworks, but if it's not connected, if this individual does not feel confident, is not considered in the delivery, is not considered in the design, and it's not considered in the actual and constant delivery of care and monitoring and evaluation, this system, even if it's beautiful, it won't serve the most vulnerable individual, and therefore will not serve other individuals that are properly right holders according to their documentation. So the current health system approach to healthcare has been limited to rigid healthcare delivery models, health system financing, and changed very little. And it's also deeply rooted in the past with few adaptations to current migration trends. And it's not considering the heterogeneous and mobile nature of migrants. So with this framework, we're attempting to address migrant, asylum seeker, and refugee health. And it requires more than legislation reforms. It requires more than empty political discourse, and it requires translational policy, accountability measures, funding, and of course, political will. In my experience as a medical doctor, as a global health scholar, and personal experiences navigating the healthcare system with migrants, this helped me understand interactions of people, that we need to think about people, to design services for people and not think about systems without considering them in the system. So the current analytical approaches to addressing migration and health don't fully capture that dynamic experience. So a way forward to that is to try to take that cube and place it into a way of measuring this. So you're able to sit down, see a document, a health, to address the health governance, and see a policy, a document, a guideline, a protocol, a proclamation, a declaration, and see if it covers availability, accessibility, affordability, and quality, and then see what percentage does it adhere to the human right. But one thing is el dicho al hecho, and another thing is what is the actual experience. So you cross-reference that with individual interviews with people on the field, with migrants, and you complement that, and you're able to not only propose barriers, propose ways of addressing barriers, but also consider the context, individualized context. And as we saw with the case of Avelino, his inability to access healthcare was in part due to deficient implementation of AAAQ standards, while his successful diagnosis and treatment was possible to the work of an NGO. And this ultimately leads to the question, how can we solve access to healthcare, and is there a way forward? So with that, I would like to say that I would love to discuss this and other things. This is a way of putting it all together, and this is the final thing. As I mentioned in my dissertation, I wanted to be a lawyer when I was growing up, but then I became an advocate, and I realized finally that physicians are truly the natural attorneys of the poor, and the social problems should largely be solved by them. With this, I would like to thank the Department of Global Health and Social Medicine for enabling this young, passionate, and oftentimes very stubborn doctor the opportunity to represent the millions of voices of people around on the move. To my thesis mentors and advisors, Joya included, thank you for the willingness to share your experiences and passion. To those who generously enabled me to study and learn, eternally grateful. And for those whose stories inspire my work, it helped me understand their endless journey and how the most significant push-pull factor, talking about theory, is love, and how we need to turn the wrongs into human rights. So with that said, I have so many references, I could share them with you. And with that said, I open this up. Thank you, I spoke a lot, but I'm happy to hear if there are any other questions, to just have a nice coffee and conversation. Thank you very much for your time.
Wonderful, wonderful presentation, Anna, Chris, and I think your wrap up and focus on love and compassion and humanity is so important. I mean, it is. We always talk about social determinants, and we rarely talk about love and compassion as a social determinant of health. But we see how detrimental to health mean-spiritedness is, and racism is also a social determinant of hate. So it's a good reminder. As I'm waiting for questions, you have just one comment. Great presentation from the Elizabeth Campa, who's also a graduate of the program. I was absolutely stunned by that telegram. I mean, that was a showstopper. So I want to ask you, one, where you found that. And I know we've got historians on the line. And then the second is, it's curious to me, of course, that was in 1918, in the at least the year that the last big global pandemic was. Did you? And I know that COVID wasn't the focus of your work, but how do you relate some of these forces, people on the move, with the pandemic, the economic fallout of the pandemic, and how you think about that?
So, to answer the first question, and I think it relates to the second question, it was I would have loved for it to be my original find, that telegram, but it wasn't. And I have to recognize that for those historians who are interested, it's called The Ringside to a Revolution. It's a book. So I wanted to understand what was the history of borders? Why were borders created? Borders, I had this idea that borders are socially constructed and humanly created, but the world wasn't just popped and you had wiggly lines like cartoons that you go back and you see the Looney Tunes and it doesn't exist. So who created borders and why borders were created, and who created the passport system, and what was that experience? And it was very interesting to see that the history of the US-Mexico border is deeply rooted in dehumanization and racism. It started, for instance, in the late 1800s, following or between the US Civil War, where enslaved African individuals that lived in the South attempted to cross the border to Mexico rather than moving towards liberated or Republican at the moment states, which were against slavery. So they even blamed those enslaved individuals attempting to cross to Mexico. They created this mental illness called drapetomania. And it talked about, and it was published in a journal, medical journal, talking about this mental illness only characteristic amongst enslaved individuals, saying that they have this mental illness that makes them want to escape their slave owner. So that's a little bit of the back history, and I just wanted to learn, what does that have to do with Mexico? Then we had a lot of vigilantes at the US-Mexico border, detaining enslaved individuals and bringing them back to the crops and the plantains. And then you had that distinction between the nationals and individuals that are owned by a country. And then in 1918, there was a lice outbreak. But at the time, you already had a lot of circular migration between Mexicans and to the US and back. And that's when they started to decontaminate, and they used decontaminated sites at the US-Mexico points of entry. And that's when they started to say, we need to be Laos Mexicans. So that's a little bit of the story. And they in my thesis, I write about this as well. In 1918, there was the Inspection of Aliens Manual for ICE, or United States Customs and Border Protection, that they, and I quote, they say that that they want to avoid, and quote unquote, don't quote me on this, but retarded, homosexuals, patients infected with TB, and all of those were migrants. So they dehumanized individuals at the U.S.-Mexico border. They were bare naked, and they were trying to avoid infectious diseases to come in. And that's at the same time that PAHO was created to avoid the movement of illness or infectious diseases to the US, and it was funded by the US. So you have the US David Rockefeller Foundation. And surprisingly, coming about TB, they did not want to sponsor programs for TB, even if TB was prevalent in Mexico, because it was a social condition. So that's a little bit about the history behind that telegram. And at the time, who could avoid Donald Trump on the news? And while I was reading this book, I read this dirty, lousy, destitute Mexican migrants arriving at the border daily, quarantine immediately. And then you see Trump doing exactly the same thing, saying these invisible enemies, they're coming in, invading our border, and activate Title 42, which is embedded in this xenophobic and racist history of the US migration system. So it's all deeply connected. And to answer your second question, I think that right now, COVID-19 only exacerbated the social, political, cultural, economic conditions in host countries, in transit countries, and in resettling countries. As you see in the sharp increase of Mexicans exiting the country during the pandemic, there was lockdown. And more Mexicans were leaving the country than before, and that's a reflection of how the country in Mexico did not handle poverty and impoverished individuals. So I think that COVID-19 is here to stay, and it's here to tell us that we need to look at the poorest to help them. But unfortunately, there's so much political movement around the word migrants. There's some efforts that I'm excited to see what happens. I hope I'm not heartbroken, but I do think that the new administration needs to look at this, at the impact of the history of the conditions that we're creating in other countries, and how these will continue to happen, and that migration actually brings prosperity. And that to change and shift that narrative of migrants, disease carriers, because they're not, they're cultural carriers. They bring prosperity, they bring cultural heritage. And I think we need to change that narrative. And for that, we need to give them a chance. And for that, we need to have them alive and healthy, them and all. So I hope I answered your question. And I'm happy to open any questions of any people. I might not know, but I might know people that might know people that might know. So I'm super happy to just take any questions. I don't know if we were able to take the webinar session. And
please put your questions in the chat. If you want to raise your hand, I will try to call on you. I think it should work. Love to hear some questions. We have another 15 minutes, I think.
Or comments.
Hey, Scott. There you are.
I was fascinated likewise by that telegram and by that this long-term association between quarantine and immigration, and usually a racism around the application. Certainly, in 1893, the U.S. the Marine Hospital Service, which becomes the U.S. public health system, which eventually becomes part of the CDC, is increasingly empowered in the setting of increasing European immigration to quarantine and restrict. At that time, it's associated with Eastern European Jews and other populations, and we can see how that's translocated in the 1918 telegram that you had, and certainly how it's translocated into contemporary racism today and its application at the border. So it's interesting to see those continuities, for sure, and tragic.
So comments, questions, I'm open to just seeing people. And maybe why are we all here, if you want to talk about it?
I'm going to actually call on you, since I'm going to use that prerogative, because I see my old friend and our graduate Lisa Parvin on, and Lisa, interesting that, you looked at sort of migrant populations local to Bangladesh. And I'm wondering if you are seeing or aware of anything. Sorry to cold call you, and congratulations on your baby. If you're seeing anything like that in Bangladesh around COVID with the river gypsies or the Bedi community.
Yeah, hi Joya, nice to
Hi,
see
Lisa.
you. Hi Anna, nice to meet you. I've been listening to your presentation, wonderful presentation, but I had to keep myself muted because I had my 9-month-old baby with me, but she is now napping, so she's about to wake. So
if she wakes up, we'll welcome her.
Yeah. Very interesting to see some of the parallels, because in your case, it's coming from a, like, quote unquote, a different country, but I totally agree with you. I don't believe in having borders. And I think after next few generation, our next, people will gonna look back to us and question, like, how dumb you guys were to divide artificially yourself with this kind of socially constructed borders. So that's my vision for future generation. So in my case, what I saw is very similar historical marginalization of ethnic minorities based on their migratory work nature. So very similar. So my question for you would be, so you looked into in terms of people coming from Central America to the US, right?
I mostly focused on this presentation. On my thesis, I tried to narrow down as much as I could. I only made it into people that speak Spanish.
Yes.
But yes, for the purpose of this presentation, I narrowed down into individuals who initially sought migration or sought their migration journey through many Central American and Latin American countries through Mexico, US, or those who ended up resettling in Mexico because of X or Y reason. Call it Title 42, call it deportation, call it whatever you'd like at the binational US-Mexico policy. So yes, I specifically focused on that region.
Yes, so coming to all the way to US and also who remained in Mexico, right? Yeah, so my question is, like, have you did some analysis on how the previous administration, like Trump's administration versus maybe Bush or Obama's administration, how those policies impacted? Do you see any difference of having a Democratic administration versus Republican, basically, or did anything change for these migrants?
Good question. So not a deep analysis, but I could tell you from conversations I've had with migrant stakeholders that it's not their first time either attempting to cross. For instance, I could tell you that the Obama administration was the first one to implement those, what we call cages, in a response for the 2014 Central American unaccompanied minor migration to Mexico. And this comes from a conversation with the then vice consul of El Salvador, that she was actually in the field. And there was this connection, organized crime connection in El Salvador. I cannot claim as a general knowledge, but this is just an individual conversation with someone at a political position. So they didn't know what to do with this incredible surge of unaccompanied minors, and there was no option to actually either admit children or not. There's a binational agreement between Mexico and the US that if there's a child, this child, if it's Mexican, they're returned to Mexico and they become part of the DIF system, which is a child protection system. But if they're from another country and they're unaccompanied and they don't have any sort of family member to connect with, which is fairly common and it's happening right now, they're immediately sent to these areas until they find a family member, and after 3 months they're sent into an open adoption system. So I could tell you, to answer a little bit of your question, I'm not an expert on policy, but I could tell you that reading and going deep into the literature, you could see that there's several instances of how migration policy, even before the Jimmy Carter administration, we could go Jimmy Carter, we could go Ronald Reagan in the 80s, have different policies that impact and that create, as a consequence of a huge wave of migration, and that wave of migration ultimately creates new policies and creates new challenges, which are all deep connected. So can this be changed? Yes, but I think that the global commitment needs to have monitoring, needs to have accountability, needs to have a way of, one, supporting countries, because there is the Global Compact for Safe and Orderly Migration, and there are ways. Is this unique to the Trump administration? No. Will this happen again? Probably, if things are not changed in a way. I don't know if I answered your question, but I think that this is happening as well all over the world. There's this huge situation with migrant individuals, and they're seen as a burden, and as a burden that countries don't have the economic capacity to respond to. And if they do, there's this legally binding thing that if I give my hand, they will take the foot. That's an expression, but in fact, it's not. So will this continue to happen? Yes, it's happening all over the world. Did this start now? No, it's been happening for centuries. Is there a way of doing something better? Yes, there is. Is COVID-19 an avenue to do so? I think it's absolutely an avenue to do so. And in fact, there are conversations with the Biden administration right now, which I've been reading on the news, that there needs to be some duty of care. And I think that there are many ways that we could do it. I'm not an expert, but I'd be happy.
Do you know if they are eligible to receive COVID-19 vaccines at the border when they come?
That's a really good question. So in theory, del dicho al hecho, in theory, migrants are included, in fact, in Mexico within the scheme, because in Mexico, it was irrespectively of your documentation status. In Mexico, I know that migrants are widely accessing, or in theory are able to access, but there's so much fear around it if they're asked for any sort of ID. So those type of barriers to access basic public health service really takes people out of the ability. So one are the bureaucratic barriers, and another one is that they're, in theory, in Mexico, yes. In practice, I don't think so. In practice, not even doctors are having access to COVID-19 vaccines. So I would say there needs to be governance to protect.
Yeah, and I would just add, thank you, Lisa, for engaging and being cold called with a 9-month-old. And I'm also going to, Shamir put a comment in the chat, so I'm going to call on you. Also, Shamir, I've unmuted you. But I think at the border, we're doing some work in Immokalee, Florida, which is a farm worker community, which is largely migrants from Mexico, Guatemala, and Haiti. Most are undocumented. And even if you make the vaccine accessible, because they are so much basically in debt bondage, it's so hard for them to break away to get vaccinated. So I don't think Vernay is on this call, but he, who is also an MMSc graduate, has been running that program. And a lot of getting the immigrants vaccinated is, of course, assuring the legal frameworks, as Anna Chris was saying, but also making sure that there's food and transportation and the right kind of accompaniment with people who speak Spanish and Mom and Haitian to do that work. So I think there are so many challenges. Shamir, you put something in the chat about India, and of course, India is on everyone's minds, and there's such a huge migratory workforce in the country itself, not to mention immigrants. So that's why I love the people on the move thing. But Shamir, do you want to ask a question or make a comment?
Thank you, Joya, and thank you, and Dr. Anna. It's a great presentation, and particularly during this time, these people are really vulnerable, and they are. Nobody really pay much attention towards them. Like during as I mentioned in the comments, during the first lockdown, a government of there is a federal government, there are state governments, millions of workforce, like they are unorganized workforce. They were in Delhi, they were in Mumbai, they were in Ahmedabad, Gujarat, and Kerala. In my state, it's a small state with a population of 35 million, but we have a migrant workforce from northern part of India. It's around 2.5 million. So during the first lockdown, they all had to go back to their country. There were no buses, there were no transportation system, there were no railway services. And sadly, these people, they started traveling.
Shamir,
you cut out. Oh, you went on mute.
Yeah, because of the noise. But Shamir, I was able to listen to you.
Yeah.
Yeah, no, you're fine with the noise. No.
Yeah, sorry, no problem.
Yeah, we can hear you. Yep.
Yeah, I am here. So, they, in a nutshell, they had to move across the country with limited resources. They had to go with their family members and their kids, and they all moved with barefoot, and some died before reaching their destination. So, and then now, for the vaccine strategy, I don't think, I never heard anybody talks about them like they are the priority people to get vaccinated. So I don't know how. My question is something like, how do you take care of those issues from the point of policy?
Yeah, that's a great point. So the issues of migration, even within the country.
Yeah. Inland movement.
Yeah.
So, and thank you for that question. I've been trying to understand a little bit more on the situation experience in India. I know that it's one, India, we have to see it as this sort of continent that has different cultures, indigenous or not indigenous to India. You have different religions inside of India, and you have to find different approaches. And it comes to the AAAQ of if it's accessible, acceptable, of quality, if it's considering the individual's ability to seek care, to receive care. But then you add mobility to the picture. And when we talk about people on the move, you could call them Muslim minorities moving through an entire country that is in a crisis. You have individuals from, I don't know if you have in India been experiencing issues to access based on a caste system. I'm very ignorant in that sense, but you have this multi-layered and dynamic experience of personal and individual health-seeking experiences, previous and current, as well as the capacity of a country to respond to that. And then you have people moving. You have people moving because of lack of employment. You have people moving because they lost the main provider. You have people moving and trying to access their right to health. But you also have people moving from one location to another because of climate change. You have people moving because of dire poverty. You have people moving trying to search for prosperity, or a lot of people have died in one province, and there means that there's employment there. So you move from that place to another. So you have a lot of different conditions that I'm not an expert on India, and I cannot claim that. but I could tell you a little bit about those that are internally displaced. And this is a situation that they're unfortunately not considered legally as migrants. And this puts them in a very vulnerable situation because they're citizens. And therefore, if the country limits access to citizens, they're but oftentimes, even being citizens, they don't have those social connections.
Yeah.
They don't have that capacity, that agency to receive humanitarian aid, because that aid is provided only for refugees, only for asylum seekers, for this, only for that. So it could be that internally displaced individuals are at even more risk than those irregular migrants, even more risk than refugees. It's something that is similar in Mexico. I know that it's similar in Syria, where you have different districts, different political control and affiliations and different response. So how to take care of these issues? There needs to be a national strategy that explicitly includes migrants in health service delivery. Explicitly. In the case of Mexico, I could tell you that's the same case in Latin America. For my experience and my colleagues, I could tell you that it's similar in Europe, even if Europe has this European Union. If you do not explicitly mention and explain and say their names, they will not have their names written anywhere in a document that says you have the next appointment available for you.
Yeah.
How can we make this build back better? I would say that we are making legislation, we're moving policies, we're having high level conversations. People are open because basically we don't know what to do. And that's where our advocacy in global health needs to push towards thinking about migrants. And this is why it's a true honor to talk about migration and health, because we need to think about our people where we work. Because one day, Shamir, that Indian individual that you met in Calcutta might be in Mexico, and I need to understand their history.
Yeah.
So it is critical to act as advocates and move forward and explain that to policymakers and include explicitly all, say their names and make a space for them in the hospital.
Great. All right. Well, I think we're at the end of time, but thank you, Anna Chris, for such a fabulous presentation, and it went so fast. Scott, would you like to close us out?
No, you guys did great. Thank you so much, Dr. Anna, and obviously Joya, and to everyone who was watching today. Thanks for closing out the seminar series this year in such wonderful fashion. Everyone have a wonderful summer.
And let's remember, love is a social determinant of health. That's wonderful.
Thank you.
Yes.
Bye.
Thank you.
Thank you. Thank you so much, everyone.